Thank you to Barbara for such a gracious introduction. And thank you also very much for honoring me by inviting me to join you today. I don't live in Tanzania. I just came back from a first ever splurge, going off to see animals. On every previous visit to low-income countries, including like 91 to India and 35 to Liberia, I met everybody with TB or HIV or lepromatous patients or kids who suffered from vaccine-preventable diseases, but I'd never taken the time even to see the Taj in India or to see the wildebeest migration in Tanzania. And it was fun. At the end, if you'd like, I can show you some really great pictures, by the way. But it's a great honor to be here, and it was wonderful to have met Barbara 5 years ago when she was just thinking about getting the Global Health Corps going. And I congratulate Barbara and everyone else involved in the Global Health Corps for the remarkably good work that they've done. No one in the world believes more than I do in transformative experiences, and I'm really thrilled that all of you are about to embark on one. If I hadn't had one in 1966, as an AFS high school exchange student whose first airplane ride was from Dayton, Ohio to the Philippines, I'd probably still be living in Dayton, which is a wonderful place full of charming people, but I wouldn't have had the opportunities I've had over the last, are you from Dayton? This is almost as good. But she would certainly get an A++ in any of my classes without having to even come to class. I'm going to make some remarks, but you should feel free to interrupt me at any time. I've been asked to address 5 questions. What have been some of the key turning points in global health? What have been some of the key themes in the evolution of global health? How have key actors and actions evolved? How has funding for global health changed? And what lessons emerged from key facets of global health history? I'm largely going to give you a kind of Skolnik's take on the history of global health in 60 minutes or less. Please interrupt me at any time, and by the same token, we'll save plenty of time for questions and answers. My normal mode of teaching is completely interactive. At Yale, they call that cold calling, which means I look at you and ask you a question you're not prepared to answer. But I won't do that, but I'll just ask, and if you think you know something and can contribute, I'll look at you and you can raise your hand. How many of you have taken an introduction to global health at some stage of your life? Okay, good. My remarks are going to focus on that part of global health that's really a subset and that concerns the health of people in low and middle income countries, particularly poor people and marginalized people in low and middle income countries. I want you to understand some of my biases as I do this, and I want to ensure that as far as possible you leave the room with the same biases that I have. So let me be completely candid about that. So let me start by saying 3 or 4 things that I hope will help you to frame. I hope everything that, nobody here was my student, right? Okay, too bad. But I want to lay out a couple of principles that I hope you will consider as you go through your global health core experience. One is, however horrible it might seem, I want to suggest that you think about global health in the countries in which you're working, including this one, to think more like a minister of finance than a minister of health. Why do you think I would say that? Why would I encourage you to think like a minister of finance instead of a minister of health, particularly when we're thinking, for example, about Liberia? Anybody? Well, let me start this way. Please don't be shy because I take it really personally. What are the leading? Go ahead. Go ahead. Please go ahead.
Because in the end, the finance ministry is the one that is giving the money for these health sector projects.
One is the Minister of Finance controls the purse strings, that's true. What is it that poor kids in Liberia get sick and die from? What are the 3 leading causes of death of poor children in Liberia, Sierra Leone, Mali, Burkina Faso? Anybody, you can just stand up and scream.
AIDS to be malaria.
Malaria will be high up there. It may not be among the, it'll be one of the top 3 or 4. Malaria will be one. What else?
Diarrhea.
Diarrhea, go ahead.
And pneumonia.
Pneumonia. So normally it'd be pneumonia, diarrhea, malaria, HIV in some countries as well. And why do you get diarrhea? Where do you get diarrhea from? Not you personally. None of these questions are personal. Where do you get diarrhea from? Poor water. So does the Ministry of Health in most countries control investments in water supply? Actually, in the olden days it was. It's almost never the case anymore. What's the single best investment you can make in development in low-income countries? Education for who? Girls. Does the Minister of Health control the schooling of girls? Right. Okay. So if you go on and you look at the underlying causes, the causes of the causes, why is it that kids get TB, why is it that kids get malaria, diarrhea, pneumonia, it turns out that the Minister of Health doesn't have much to do with any of them. And these are sitting in other ministries. It's the Minister of Finance who really has these decisions to make about intersectoral allocations of resources. And if you think like a Minister of Finance, you will certainly miss understanding why it is, not to mention some of the underlying social determinants, which ministers of health are better at usually than ministers of finance. Ministers of finance have all got PhDs from the University of Chicago. They're all extremely conservative economists, and they don't usually think very much about the social determinants of health. I'm caricaturing, but only slightly. But you'll miss a lot if you think like a minister of health. Another thing, and I don't know, and I apologize if others have covered this, let me just show you something about your deep-seated beliefs. First, let's ask if anybody can tell me, what is cultural relativism? Some of you must have taken anthropology, right? What's cultural relativism? Go ahead. You shouldn't, right? You shouldn't apply your values to other cultures, especially when you're thinking about ethnography. You should let cultures speak for themselves. How many of you believe that it's okay for a father who sees his daughter look at a young man across the road to commit an honor killing because this is against local cultural belief? How many of you think honor killings of young girls are okay? Nobody. How many of you think female genital mutilation is okay? Nobody. How many of you think it's okay for countries not to systematically not allow their girl children to go to school? Nobody. So no matter how much anthropology you took, and I have deep-seated affection for the anthropologists and took lots of it myself, one of the challenges you'll face, as I'm sure you know already, you've got experience with and you'll hear more about, is thinking about your place both as an insider and as an outsider in dealing with these cultural issues, because at heart, all of you have deep-seated universal beliefs about what's right and wrong, no matter what you learned in Anthro 101. And I think that's an important frame, even for thinking about the things we're going to talk about today. Second, if you have two choices. Let me just pick on the young man here. You have two choices. You can buy an iPad delivered to your door for $299 or an iPad delivered to your door for $399. Same iPad from the same source. What would you pay?
I would pay the less expensive.
The lower price,
yeah.
right? He's all about value for money. This is a very sensible person. And yet what you're going to find everywhere is that people are investing in things that don't represent value for money. Whether you're thinking about society as a whole or you're thinking about value for money, specifically for the groups that are of your concern, poor people, women people, young children, marginalized people. In health, it may be true that some countries need more money, but it's also true that you could go through any health budget in any country, and you will be able, if you worked hard, to see a different allocation of resources that would yield more health for the money, more value for the money. And of course, those of you who are Americans here surely realize that we are among the worst sinners of all. Two last things in terms of frameworks. And I'll say at the end, again, it's more important how you spend money than how much you spend. Now, with great respect to Partners in Health, Paul Farmer, and other good friends, I admire greatly their quest for more money for global health. I would love to see more money for global health. I would love to see a world in which there were no wars, there was only social justice was the only orientation, and there was no need to worry about how much money there was for good things like girls' education, investing in vaccines. But I'm telling you, I'm 64 years old, I've been in 80-some countries, and I've never seen a country like that, including my own. It doesn't exist. There are never enough resources, and you will always need to think like the Minister of Finance. And you will always need to think about, if you only had $100 to spend, what would you spend? And indeed, when I worked on HIV in India initially, Manmohan Singh, the just retired prime minister, actually asked us in 1993. What he said was, look, just answer one question. If we have $100 to spend, actually what he said was so many rupees, but if I was translating, if we have only $100 to spend on HIV, how should we spend it to maximize the number of cases averted? And I want to encourage you to be thinking like that as you go through your experience and as we talk about some of these things today. Last two things. If you were anybody, if Mrs. Johnson Sirleaf, the president of Liberia, called you in and she said, do you want me to do my Liberian accent? Because I'm really good at it, by the way. I say, Minister, how you doing? You come here now, and I have a question for you. What is your goal? What should I tell the people of Liberia is the goal of our government for the health of Liberia's people? What would you say? What would you say, anybody? What would you tell Mrs. Johnson Sirleaf is your goal? You get 2 sentences. Let me start this way. Who did Liberians bury? Who did they bury disproportionately? Who did they bury disproportionately? Anybody? Pardon me? Kids. Kids, actually. They bury disproportionately. So in the United States, this share of total deaths every year will be kids. And in Liberia, it's probably around 40% of all the deaths last year were kids under 15, and a huge share of those, of course, were kids under 5. So what would you say if you knew that? Who do you want to bury? I make my students look at me and say, people like you. Right. You want to bury people like me. You don't want to be burying young kids. So in a way, what you could say is, whether you're thinking about the history of global health and the lessons, or you're thinking about the work that you're going to be doing, what you want to do is you want to bury old people instead of young people. You want to do it as fast as possible, make the transition as fast as possible, and do it at least cost. These are some of the principles I would encourage you to think about. You want to bury, if you're working in the lowest income countries, you want to bury old people instead of young people. You want to make the transition as rapidly as possible, and you want to do it at least cost. And if you were the Prime Minister of Norway, and I don't do a Norwegian accent, though it's a beautiful place, if you were the Prime Minister of Norway and you called on the minister and said, look, I'm running for re-election and I have one line I have to say about health, what would your goal be? What would your goal be for, if you were the Minister of Health in Norway? What should the government's goal be for health in Norway? Pardon? Yeah, Norway's actually, it's probably got less than 2 total fertility, and they probably want to outbreed the Swedes, but I'm not going to get into that here, and the Danes. But what would you say? True, you do want elder care, but what's your goal? How do you want people to live? Both here and in Norway, how would you want people to live? How long do you want me to live? I'm 64. Let's hear what she says about this. You want me to live a long time, right? And in what state do you want me to live? Healthy, right? And then, let's be honest about this. I'm not going to hold it against you. Then what do you want to happen to me? I'm 87 or 88. What do you want to happen to me then? Right, like really quickly and not costing the taxpayers any money, right? Okay, and that's totally okay. She would get an A- in my class for insulting me terribly. But no, so if you're in Liberia, you want to bury old people instead of young people. You want to do it make the transition as rapidly as possible. You want to do it at least cost. If you're in Norway, what you want to do is try to ensure that everybody lives a long and healthy life, do it at least cost, and then have them all drop dead suddenly before they get sick and enter into disabilities, right? I would encourage you, I don't know if others have said these things, I would encourage you, whether we're talking about global health, history, or content, or both, which is our aim today, to think hard about these frameworks and hopefully to keep them with you as you go on. You can see this, hopefully you can see this okay. Yeah, it's okay, it's a little bit small. So this is the history of global health, according to me, with my daughter's help for the nice, by the way, I did fly 42 hours back, and again, I'm very thankful that the Global Health Corps was kind enough to allow me to present today, which was the only day that I could make it because I had this long planned vacation. If there are any typos in anything, it's entirely my fault because I was tinkering with it on the train, and I didn't even know my name when I was doing it. This is the history of global health. You notice it starts with UNICEF And it ends with the publication of my book. That's all there is to say. That was the first. I intentionally ended it at 2007 instead of 2013, but I'm going to fill in some things. Now, I'm going to give you all know what the Reduced Shakespeare Company is? Anybody know? Please tell us what the Reduced Shakespeare Company is. Right, how long does it take them to do Hamlet?
It takes them a very short amount of time to do
Right,
Hamlet.
like they do Hamlet in 5 minutes and some other, The Tempest or something, in 7.5. So I'm going to hopefully help you see some themes in all of this, but this is going to be a little bit like the Reduced Shakespeare Company. So what I want to suggest to you, if you look at the history since World War II of what we now call global health, a world that originally had relatively few actors, dominated by the institutions of the United Nations, that has now become a world of profound interest for students, for taxpayers, for governments of both high and low-income countries, for researchers and for everybody else, and that now has a large number of actors and many different poles of both policy making and action. It's really dramatically changed. In a somewhat caricatured way, what I could say to start is that I hope you like my Hans Rosling imitation too, though I can't do the Swedish accent, but Hans is a complete genius. I encourage all of you to watch all of his videos. You should have like a late night Hans Rosling, gapminder.org video pizza party before you go. I mean, I have an enormous regard for Hans and his work and what he's done. But in a somewhat caricatured way, what you could say is that after the war, we had a world in which there were these UN agencies of WHO and UNICEF, that as we moved into really into the 80s, I'm going to focus first a little bit on actors, into the 80s or so, WHO fell into some disregard. And you have to remember that the World Health Organization is completely dependent on the largesse of its member countries for its budget. It's not a financing agency. It depends on contributions, and not everybody pays. And I mean, Gates has a budget way larger than WHO, by the way, even now. So WHO fell into some disrepute. And at that time, the world lessened its respect for the intellectual contributions of WHO. At the same time, around this conference on primary health care that we'll talk about, UNICEF appointed a director general who has become a great hero to many people named Jim Grant, and a person of remarkable strengths and talents. So as WHO's reputation waned, the reputation of UNICEF began to grow, and UNICEF in many ways really became the primary intellectual force for what was going on in global health. But things don't last forever, and eventually James Grant died and was replaced by a person of great talent, but one who focused a lot on child rights, which may be incredibly important. But if you're from Ohio, as this young lady and I are, it's a lot easier for your parents and friends and relatives to understand why you should give a quarter to immunize a child than why you should give a quarter to protect child rights, which seems to a lot of people like a very hard concept to understand. And about that time, the World Bank, which had never been involved in lending formally for health, decided that it should become involved in health. And it brought to the World Bank a real powerhouse of intellectual talent, headed by John Evans from the University of Toronto, whose son actually is now the head of the health group at the World Bank, Tim. And Nancy Birdsall, who's now, as many of you know, the head of the Center for Global Development. Dean Jameson, who may be the best global health economist ever in many ways. Put them all in one place at the World Bank and asked them to develop an intellectual foundation for the bank's work in health, and then brought in some hardcore operational people like myself, as my director said at the time, to teach those useless academics how to do real World Bank work. And the bank then, around the development of the 1993 World Development Report, began to seize the mantle of intellectual leadership for global health in ways that were really seminal and that in some respects, in many respects, really continue. And we can come back to that because there's some really interesting discussions then around the battle between those who think health is a human right, those who think that health is an issue of human productivity, those who think both, and those who see conflict between these ideas and those who don't. So the bank became a kind of really important intellectual force. But then HIV came about. Actually, it had just started. And the first antiretroviral drug was developed here at Yale. And a movement began both to get governments to take HIV more seriously, as you know, led first by gay men in San Francisco and New York. And at the same time, a bunch of folks, including Paul Farmer, Jeff Sachs, and others at Harvard, if I remember correctly, took out a full-page ad in the New York Times and said it was unconscionable and unethical and immoral that people in better-off countries should have access to a life-saving drug when HIV should be a death sentence for those in low-income countries. And to my mind, that's where the point from which I date the kind of global health movement. From then on, it wasn't just international health and a concern of people in high-income countries for poor, marginalized people in low-income countries and the diseases that they had or might spread. From then on, I think there really began a kind of movement that you see represented by your presence today, by Barbara and her friends starting the Global Health Corps, by Vanessa Carey starting this medical corps, and by all of my students wanting to be Paul Farmer, or to work for Doctors Without Borders, right? So this global health movement woke up one day, and what it said is, you know, the World Bank, I mean, you'll be amused to know, I don't know if this is on, it's filmed, it's okay. Paul Farmer used to introduce me as a good guy from a bad place. Jim Kim, who I know better and is a dear friend, Jim actually left off the bad place part, which was good, and that I think got him his job as president of the World Bank. But people began to lose confidence in the bank as this global health movement began to push and push and push and got very impatient, pushed partly by Paul and his friends, pushed partly by Jeff Sachs, and pushed the work of the Commission on Macroeconomics and Health. And these folks woke up one day and said, you know what, even if the bank's doing okay and we're over the days of structural adjustment and the bank is really not immiserating poor people in poor countries, the bank is a ponderous institution that demands too much of countries. It has too heavy a hand. It can never meet the needs of this new world in which we now have X number of people affected by HIV, almost none of them with access to antiretroviral therapy, and we need as a world a new way of doing business. And UNICEF, which continued to, in some respects, be not so well regarded as it was. And let me just give you an example. Another thing you should know, this is a true story about Jim Grant, and I think can also be helpful to you in thinking about what you do when you're away. Mr. Grant was in El Salvador one day and asked his colleagues, so tell me, how is the immunization program going? And they said, Mr. Grant, we wish that we had better to report to you, but there are real problems. As you know, there's a civil war in El Salvador. And Jim Grant said, well, then stop the damn war and immunize the damn children. And this is not apocryphal, this is real. And in fact, that led, as many of you know, to this thing called Days of Tranquility. And I have several friends who go out with flak jackets. They're not allowed to be photographed wearing them in Somalia and other places, trying to ensure that warlords stop fighting so kids can be immunized. So the world began pushing really hard, began to see the World Bank, which by then had become the preeminent place intellectually and was lending about $1 billion a year for health in low and middle income countries. And they began suggesting that a new way of doing business was needed, that these old ways were not going to be sufficient in this new world of HIV. They didn't love UNICEF probably quite as much as they had before, and this led to the formation of the Global Alliance for Vaccines in 2000, Gavi, and the Global Fund to Fight AIDS, TB, and Malaria, the Global Fund, in 2002. If you had thought about the world from 4 or 5 years before, this would have been unimaginable. That an organization was needed to do the work that Jim Grant had made famous at UNICEF was just unimaginable, but it came to pass. And it was also not so easy to understand how the world had changed so much that we needed a new organization that in principle could act quickly, that would be more representative than the World Bank, that would have country partnerships that would be more democratic in principle than the way the World Bank worked, and that was the Global Fund. Now, in the last, and then of course what happened, actually it happened a little bit earlier, is an entirely new actor came on the scene, and that was the Bill and Melinda Gates Foundation. Foundations that actually been, as we'll talk about, instrumental in global health work, with Rockefeller really being the initial financer of all things global health in the early days. But Bill Gates is said to have read the 1993 World Development Report and said to people, how is it possible that the polio vaccine was invented in 1950, began to be disseminated in 1954-5, I think it's maybe 4, but it's certainly 5. And yet now we're sitting in a world, he said in 1987, 88, actually 93 when he read the report, how is it possible that we're living in a world in which there's still polio? How is it possible that it's taken the world 50-some years to get rid of polio? What kind of world is this? And Bill Gates called, I think, in the authors of the report, and this, the 1993 World Development Report, which we'll talk more about, is said to have been really instrumental in helping Bill Gates catalyze his ideas about establishing the Gates Foundation, which today, of course, is an enormous player whose amount of grants yearly is considerably in excess now of anything done by UNICEF, the World Bank. We're also looking at a world, as we'll talk about, where the Global Fund itself is now about 4 times a year bigger in the amount it grants to countries than the World Bank. Now, as all of this has happened, also the world also began to get together more in thinking about failures. If you were the president of Merck Pharmaceuticals, with great respect, what's the one word that would represent your goal? What are you after as the president of Merck Pharmaceuticals? Profit. I always have these students who say, I want to do really good things for the world as the president of Merck, and I want to invent things for neglected tropical diseases and new drugs for TB, which until a few months ago didn't have a new drug for 50 years, and new diagnostics and all, and that would be commendable. But actually, you'd lose your job in 5 minutes. All of these companies do some wonderful work, as we'll talk about, but that's not their goal. Their goal is shareholder value. So the world woke up to all these things. This movement pushed a lot of different things, and in 1997 created, for example, the International AIDS Vaccine Initiative as the first product development or public-private partnership for health. And now there's one of them for practically everything that you can think of. The International Partnership for Microbicides, the Global Alliance for TB Drug Development, et cetera. And finally, the world also decided that the partnerships that existed were too top-heavy. They were too much us and them. They were not sufficiently representative of the world as a whole. They were too oriented toward the countries of the North. They failed to take account of the views of affected people. And so they began in 2001 to create another whole new range of bodies. And the first of these was the Stop TB Partnership, but Rollback Malaria is another one. And the idea here was that global partnerships representing a broad array of people and pretty much anybody who wanted to join, but certainly including affected people, would be sitting side by side with WHO and helping to advise WHO on how they might address some of these issues. So if I were going to focus on 4 or 5 points only, as you looked at the broad sweep of history of global health, since World War II, I would say something like that. And we'll talk a little bit more about, they're really probably inspired by my book. There really has been a lot of interesting things happening since 2007, and we will talk about those, I promise you. Again, please don't hesitate to interrupt me at any time. So as you think about that timeline, and I've mentioned some of these already, there's been this substantial evolution of actors. You could say today, in fact, not only has it been an evolution from a small number of actors to a large one, but if you knew the nitty-gritty on this, you might even say there's too many actors. And actually, not all of them are adding value, and not all of them are adding value for money, but that's something you can decide for yourself. So let me just say a few things, mostly about who plays, but also a few things about institutions. I mean, in the early days, in the early days, when I was your age, for example, everybody interested in science read 2 books. Everybody read Paul de Cruz's Microbe Hunters, and in addition, everybody read about Albert Schweitzer. Has anybody here ever heard of Albert Schweitzer? Albert Schweitzer was, see the older folks over there, they've all heard of Albert Schweitzer. So Albert Schweitzer was a leprosy doctor who set up a famous leprosy hospital in Gabon. And in my day, he was kind of the Paul Farmer of my day. Everybody read, I don't remember what the equivalent of Mountains Beyond Mountains was, but everybody read about Schweitzer. And after you read about the discovery of the microscope and Koch discovering the TB bacilli and Pasteur discovering pasteurization, then you went on and cemented your interest in science and medicine by reading about Schweitzer and decided that you wanted to go out and be a leprosy doctor in Africa, which nobody had ever been to, of course, in my day. So in the early days, and there's some very good materials on the history of global health and the deeper history, a lot of the work of what we call global health now, at least in terms of working with the health of poor people in poor countries, was done by missionaries, by the precursors of NGOs, by NGOs. And that work, of course, continues in many instances. As I mentioned earlier, the Rockefeller Foundation was really at the core of public health work, both in the United States and internationally. The Rockefeller Foundation, if I remember correctly, was the original financier of the first public health schools in the United States and financed early work, for example, on yellow fever as well, and retained this interest for a very long time. So it's not like foundations are new to this business of global health. They've actually been in there for over 100 years and have been very, very important, though the role of foundations other than the Wellcome Trust and Gates Now is substantially smaller in some respects than it was, though there's also all kinds of new foundations like the Children's Investment Fund and some others. Lots of folks, Bill Gates and others have challenged billionaires to give, either through the Gates Foundation, as Warren Buffett has done, or to give themselves. And you'd be pleasantly surprised in some respects to see the substantial number of people with money who have set up foundations now that are giving directly or working through other NGOs. I mentioned WHO and UNICEF. For those who don't know, WHO and UNICEF, of course, are agencies, what they call specialized agencies of the United Nations system. The World Bank and the International Monetary Fund as well, by the way, are not. But they have a dotted line connection to the UN system, but they are not UN agencies. And then there's the bilaterals, which have been involved for a very long time and continue to play a very large role, as you'll see in the table I have on financing. In the US, we have USAID. In England, you have DFID, the Department for International Development. In Australia, you have AusAid. In Norway, you have NORAD. In Denmark, you have DANITA. And all of the high-income countries, and actually even Quebec has its own foreign aid program, have development assistance programs. USAID has been the largest in total dollars. The Dutch, I think, the Danes, as you know, give more per capita than we do, but we give the most by a lot, as you'll also see. And these organizations have all had their niches. USAID has been deeply involved in family planning. It's been deeply involved in immunization. It's been deeply involved in the child survival movement. And the work we did in India, some of which turned out to work very well and to have been sustained, was really built on the backs of Danish assistance to India. The Danes worked with India, I think in an absolutely model way, for example, to pilot efforts in leprosy, TB, and cataract blindness control. And then when the lessons of those pilots were learned, exactly as you read should happen, then the government and Danita asked us at the World Bank to help them scale those programs up in ways that turned out in all three cases to be very, very, very successful. Though the gap in TB in India is still a very large one, they made very substantial progress from earlier. And without Danita's support for India's piloting these efforts at changing the paradigms for these, this wouldn't have happened. So if you're really interested, you'll see different organizations, like the Aussies in principle concentrate on the Pacific and parts of Asia. And most countries concentrate on former colonies except ours, which has consistently worried about child survival and family planning. One thing we'll talk about, by the way, a little bit in a few minutes is none of the organizations are giving much for non-communicable diseases, which is really interesting. The World Bank continues to be an important provider of financing for health. It eventually created a grant financing wing. Mostly it lends, but it lends at concessional rates, no interest, long repayment terms to low-income countries. I think it's fair to say that the World Bank continues to be an important intellectual force in global health and an important resource on the research and on the practice side, but doesn't have anything like the preeminent role that it had in the mid-90s around the development of the 1993 World Development Report. But it's certainly true that the bank continues to produce some research, some critical studies, and some lending and evaluation work that remains really important. And if you stay in this business, you will want to pay attention to it. And Gates has gone from being a relatively small group with a lot of money to, I don't know, the Gates Foundation must have now something like 3 or 4 times the number of people working on health. I could be wrong for the film, but it's, I think there's something like 700 or 800 people at the Gates Foundation, probably only around 200 at the World Bank working on health. And I think most of you know the work of the Gates Foundation. The Gates Foundation, to a very large extent, is focusing on trying to help the world find technologies that can enhance the health of poor people in poor countries. I don't know anybody who dislikes that, but given the enormous size of the Gates Foundation, some people wish that the Gates Foundation also focused even more of its attention either on programs that make sense or on helping the world to discover what works. And we'll talk about still very substantial gaps after all these years in a really good understanding of what works at what cost and what is most cost effective. But Gates has certainly dramatically altered the landscape and in 101 areas really made a big difference. Now, I alluded to this thing called public-private partnerships or product development partnerships. And IAVI, the International AIDS Vaccine Initiative, was the first one set up in 1997. And the idea here is that at the time, again, people became very interested in pushing the world harder. And there was a very strong perception, certainly in the community of people affected by HIV and their friends, that the National Institutes of Health of the United States was seriously underinvesting in HIV vaccine research and was never going to find one. You may know that under Reagan's Secretary of Health and Human Services, I think it was Margaret Heckler, announced that it would only be a few years before there would be an AIDS vaccine. So pushed by the world and encouraged by the Rockefeller Foundation again, and a fellow there named Ariel Pablo Mendez, who's now the Deputy Administrator at USAID, IAVI was created in 1997 as the first of the product development or public-private partnerships for health. And the idea was, in a world that was not on the right track to create an AIDS vaccine anytime soon, the idea was that IAVI would be a broker. That getting money, which it turns out has largely come from the Gates Foundation, but also from some governments, they would try to look for good ideas for an AIDS that might be at the base of an AIDS vaccine, bring those ideas together, and see if they could encourage the development of a vaccine in a way in which the world up until then had not been able to do. And then, as I mentioned to you, if you pick a topic, this started, neglected tropical diseases. There are orphan drug laws in all high-income countries, but there's a real dearth, as you know, of drugs, diagnostics, and vaccines for neglected tropical diseases. For TB drugs, although the drugs work, until recently there hadn't been a new TB drug for 50 years. The TB vaccine, which is not very effective, is over 100 years old. So when you're living in that kind of world, what we've got now, as I mentioned, is all these different public-private partnerships, which so far have yielded some gains, but probably not as dramatic ones as people wanted. And the idea behind these public-private partnerships, again, is very similar to IAVI. It's to create an organization that can broker knowledge, do deals on patents, offer if this gentleman's biotech company discovers something that can be used for the development of a new TB drug, then what we would do is maybe say, look, can you license that to us maybe for free or a really low cost? We'll join it with the stuff we've got from their firms because we think together that knowledge might help us create a new TB vaccine. And you take the rights in the high-income countries. You give us the rights, please, on behalf of the world and low-income countries, so that when such a TB vaccine or TB drug is created, it'll be really cheap. And that's the notion behind all of these. Often they're working with big pharma as well as smaller biotechs, et cetera. And I think everybody's hoping that before too long, some of these public-private partnerships will yield some substantial gains. And the list of them is ginormous, as we would say. Now, there's a lot of confusion, and let me just say one thing. You know, although we're talking about the history of global health, and I think it's helpful for you to understand this context, unless you want to be an historian, I would discourage you from focusing too much on process, and I would encourage you to focus much more of your attention on content. One of my criticisms of the world of global health in the last 50 years is I think that the partners in global health, to my mind, this is my opinion, but I could show you evidence, I think. I'm sure, at least evidence that would satisfy me. They spend too much time talking to each other about how to talk to each other rather than spending the time worrying about getting girls in school, improving water supply and sanitation, trying to understand better what works and at what cost, and how at the least cost we can make those transformations we talked about for Liberia and Norway. So I think it's really important to understand these things, and I'm glad that the Global Health Corps leadership has asked me to address some of them for you, but I wouldn't get too hung up about who plays or how they play unless it's central to your finding the money you need to do your work. I'd understand it because it's very helpful, but I would encourage you to focus more of your attention on how do you bring value to everything you're going to do as efficiently and as effectively as possible, for which this can be helpful. So there's a lot of funniness in my mind in these nomenclature about Gavi, the Global Fund, and the alliances. And I just wanted to say, people call them public-private partnerships. I think it's easier to think about the public-private partnerships as the product development partnerships, the Human Hookworm Vaccine Initiative, the International Partnership for Microbicide, IAVI, et cetera. I don't think, the point they're making when they talk about Gavi and the Global Fund as public-private partnerships, they're really trying to say these are different from the way we used to do business before. They're more representative. They're more democratic. They concern effective peoples. But basically, these are large global partnerships with many actors who are in the public and private sector, but they're completely different kinds of organizations than the product development partnerships. And that's important to know. Now, on themes, just two other things, if I might. So the world also woke up, and it had increasing number, there was a movement for global health. There were new institutions to help implement global health programs, get global health, support global health investments more effectively and efficiently, and Gavi and the Global Fund. There was a gigantic new player in the Gates Foundation, and much more money, as you'll see. But still, people found that there were important mismatches between the money needed and when it came and the quantities in which it came. And so people have been working ever since then on a number of innovative financing mechanisms, both to increase the amount of money going to global health, as well as to ensure that it's matched with the needs. If you're a minister of finance in Botswana, and let me pick a poor country, Burkina Faso, forgive me. Burkina Faso, you're the minister of finance, let's say, and you're working with Gavi to develop a long-run plan for financing. How long will you need money for? You're going to need external support for your program. You're quite a poor country. So when you go to Gavi and talk about it, how long are you going to talk to them about? 1 year, 5 years, 10 years?
1 year.
Probably longer. Probably longer because you want to know, if you're the Minister of Finance, that if you work with Gavi and you have a commitment to immunizing all your kids against the basic vaccines plus HPV plus rotavirus plus pneumococcal, you want to know that there's going to be money out there. You're not going to be able to afford it yourself. You want to know there's money. But if you're the head of USAID, forgive me, if you're the head of USAID, how does USAID allocate its money? 1 year, 5 years, 10 years? What's the US budget?
Every 1 year.
It's 1 year. There's this real mismatch. We ask you as a relatively poor country to make a 10-year commitment to financing, and then as the rich countries that help you, we say, well, we'll give you 1 year money. We're committed to helping you, but we're only going to give you 1 year money. So people have developed a variety of innovative financing schemes. Gordon Brown, the former Minister of Finance in England and then Prime Minister, helped to develop the International Financing Facility for Immunization. And the Brits sold bonds. The Brits and a number of other countries sold bonds. You can buy a vaccine bond, just like you supported World War II with U.S. savings bonds. You can buy a vaccine bond. They sold the bonds. A large amount of money went into the bond fund from the sale. The money was given to Gavi to finance immunizations support in the long run. And the British taxpayer is on an annual basis repaying that. And the British financing mechanisms, and other countries as well, make that an easier way of committing long-run money. At the same time, there's Unitaid. There are a number of countries, as I'm sure you know, that have an airline tax, and that money goes to help finance drugs, et cetera. So there's been an enormous increase in financing for global health, as we'll talk about. We've talked about some of these, and I'm going to give you another reduced Shakespeare. I'm sure you already have a headache. My students take Valium before they come to class, and then they take 2 more afterwards, which is really good for my son's business because he's a toxicologist. So, but just kidding. I abhor all use of drugs, but they do all tell me they have a headache after each class. And it's not necessarily one of my learning objectives for you, but if you have a headache, I'll know I did a really good job today. So there have been a number of movements, and I wanted to just highlight a few and then raise one more that's not on here. So sometimes when we think about primary health care, we're talking about levels of health, primary, secondary, and tertiary, but that's not what this is. In 1978, the world held a very famous conference that remains near and dear to the hearts of serious global health actors, and that is the Alma-Ata Conference. It was encouraged by the Russians. At first, the Americans didn't want it. And basically what the Alma-Ata Declaration says is that all countries really should ensure that they provide their people with primary health care. And that's a set of services. And that means that people should have water, they should have sanitation, they should have basic knowledge of health, and they should have access to basic health care services like immunization, well baby care, antenatal care, delivery care, and TB care. And, you know, Cuba was pretty much the model for this in lots of ways. And in fairness to the Cubans, as you know, they've done a lot of very good work this way. And this became a rallying cry. And this, I repeat, remains central to the hearts and minds, certainly not just of people my age, but even to people who are younger. The idea that at the core of every country, there should be, certainly for their poorest people, a primary health care service that ensures that the basic health care needs of all of these people are met, and met in ways that are affordable and don't bankrupt their citizens. Now, it didn't take long for the world to wake up. It was only a year, I think, or so, in which there was a big meeting on the implementation of the Alma Ata ideal. And then Jim Grant in 1982 led the world to create what is nastily, really for many people, this is a pejorative, this is a nasty thing called selective primary health care. Let me ask you a question. How many of you hope that Liberia has a working health system tomorrow? How many of you hope that Liberia tomorrow morning can deliver to all of its poor people an Alma Ata-style primary health care system? How many of you would want that for Liberia? How many of you believe that that's going to happen in Liberia tomorrow morning? Right? Okay. So Jim Grant woke up and said, look, this is a wonderful ideal, but it's not going to happen tomorrow morning. And therefore, what we must do is focus on those things that are more central than others. This idea has remained very divisive because some people say primary health care across these domains is central. How can you divide it up? But Jim Grant created this thing called GOBI, growth monitoring, oral rehydration, breastfeeding, and immunization, as the core of a movement that became the child survival movement. Later, they added food fortification, girls' education, community mobilization. But this remains also a kind of movement for global health actors, the idea of child survival. And one of the best websites, by the way, that I strongly encourage you to subscribe to is the child survival website that Bob Davis puts out in Nairobi. Bob was 1 year senior to me at Yale. He's a very eminent and very well and deservedly well-regarded immunization person who'd worked for UNICEF. If you could only read one thing to keep up on child survival issues, just subscribe to his daily newsletter, which has a fantastic array of materials, but very well focused for you. Now, in 1955, the world started the first of what became a number of campaigns, and another important theme has been campaigns. The world tried, and some of them were meant to eliminate diseases, some have been meant to eradicate diseases, but the first eradication campaign in modern times was malaria, which was started in 1955, which focused on spraying to kill mosquitoes, and which failed. The second and most famous was, as you know, the smallpox eradication campaign, which began in 66 or 67, and in 77, the world recorded its last case of smallpox, and in 1980, the world was declared smallpox-free. If you come back from the Global Healthcare and want to take my seminar, you're more than welcome to sit in. We have a fantastically wonderful time looking at these case studies of disease control. And there have been a number of campaigns since then. There's the Global Program for the Eradication of Polio, as you know. There was a campaign started, I think, in '84 against onchocerciasis in West Africa that now concerns all of Africa. There are campaign-style programs against lymphatic filariasis, schistosomiasis, the wormy diseases, etc. And even though there's been this notion of primary health care, in which a primary health care should create these services in a kind of horizontal way, the world has had a variety of campaigns, which the campaigners would say was necessary to deal with the reality of countries which for a long time to come still might not have well-functioning primary health care systems. And this has been another ongoing debate in global health, and that's the debate between vertical and horizontal. I would discourage you from spending 5 minutes with this. If you're interested, you can spend 5 minutes by going to Bill Easterly's website and seeing how bitterly and personally I was attacked by some of my former colleagues for writing an article suggesting that people should focus more on outcomes rather than on inputs and outputs. Barbara obviously didn't read the article because she said such gracious things about me. And on the website they said Skolnik knows nothing about global health, never did and never will. I won't give you their names now, but if you'd like later, I can tell you who they are. The great thing about LinkedIn is so cute because I turn on LinkedIn, there's a request, Barbara Bush wants to be linked to you, and then right next to Barbara, who I'd be thrilled to be linked to, there's the person I thoroughly detest who wrote those nasty things. You probably want to be linked to so-and-so because she has 40 of the same links as you. This is a debate that's useless in my experience, and I'm going to give you my position on this. It would be great. My position is really simple, and I would encourage you, whether you don't have to agree, but don't spend too much time arguing about vertical versus horizontal. When you go to these countries, you're going to have to ask yourself, what is the extent to which the health system, if you're working on it broadly, can do the things it's supposed to do? And if it can't do the things it's supposed to do, then how will they be done? It's not okay for women in Liberia to die in childbirth. But the health system tomorrow morning isn't very able to stop those maternal deaths. So you shouldn't be arguing about whether you need to be vertical or horizontal. You should be wholeheartedly arguing with people about under these circumstances in this country today, no matter how committed we are to the primary health care notion, how can we stop children from dying? How can we stop mothers from dying? We're living in a world where 6 million children a year under 5 are dying, and it's great that we're taking great credit because it used to be 15, then it was 12, and then it was 9. But you go and divide 6 million by 365 days a year, decide what you would be doing today if 20 747s a day were falling out of the sky full of poor children. You wouldn't be sitting in the dining room at Branford College. You'd be out there wildly protesting about the world's silence about this, even though lots of good work is going on. So I really think this is a non-starter, but you'll find still lots of people arguing about it, lots of articles, lots of people who hate each other because of this. I would just be really practical. What can be done under these circumstances today in this country? And I'll give you an example of this in one way. Well, I'll wait a second. Women and children have been a continuous theme. There's been much less success in reducing maternal deaths. People, I think, use as an excuse the idea that health systems have to work to reduce maternal deaths. They're not working in some countries. They're not going to work, so what are you going to do, as I mentioned? But the child survival movement continues to be very important. And if I understand correctly, people now who worry about women's health want women and children to be both integrated in lots of ways, but separate in others, and I think that's probably sensible. That's my view. Value for money. Some people think health is a human right and detest thoroughly the idea that we talk about value for money in health. Other people, like Ram Ezekiel's brother, Emmanuel, who's a bioethicist, has written that we have a moral imperative to ensure that we get value for money. And if you were running an NGO for health and I was chairman of the board, I would certainly say to you, John, thank you very much for coming today. The board of directors is thrilled to see those of you who are really at the forefront. Please tell me in a paragraph, the 60-second elevator speech to start, what is it that we did last year to ensure that we used our funds to improve health to the maximum in the countries on which we're working, especially for poor people. But some people still regret that people talk about value for money in health. People talk about the possibility that even in poor countries, there's a lot of money that's not being used as wisely as possible or as effectively as possible. I would encourage you at all times, I'm one of those who do think that you have a moral imperative to ensure that the money for which you're responsible is spent as effectively and efficiently as possible with extra credit for the groups for which you're concerned. Some people hate cost-effectiveness analysis because they think it leads you to perverse outcomes. I've never seen one. You can play with cost-effectiveness analysis that would say, let's invest in appendectomies for people in Scarsdale instead of maternal health for a poor woman in this is jet lag, Burkina Faso. But I've never seen it happen. But I think I would encourage you always to be thinking about value for money. And indeed, when the Senegalese took the work of the Commission on Macroeconomics and Health and took the notions of the 1993 World Development Report and looked at how the money was being spent in 2 districts, and how they might make it more effective and efficient by aligning it more with the global burden of disease in those districts, they were able, at the same amount of money, to substantially improve the health of their people. Healthcare financing is a never-ending discussion. The world, I think, now believes that we made some serious mistakes in the 80s with the Bamako initiative that encouraged poor communities to finance their own health care, even when the rich were actually getting a lot of subsidies from the government, and user fees. Today, the world is basically oriented toward the idea that we should try to encourage the development of healthcare systems that work as rapidly as possible, and even in relatively poor countries, we should try to help them develop as early as possible universal health coverage. Rwanda has shown that it's possible to cover a lot of people with a basic health care package. An increasing number of countries, as you know, now has some form of insurance, including countries that are poor and in which 20 years ago we never believed at this stage of their development would be able to do this. Countries like Taiwan and some others, which are relatively richer, have really paved the way. Ghana, as you probably know, has some really interesting approaches to universal health coverage, though they could be bankrupting themselves if they're not careful. But the world has moved a long way. But this notion of healthcare reform, helping health systems to develop to the point where they work and can deliver primary health care as well as their basic functions like supply chain, personnel management, etc., financed in ways that make sense and are progressive rather than regressive, because most of you think subsidies at one place or another, unless you're very experienced, are good. A lot of relatively enthusiastic young people like subsidies. Every time you see a subsidy, ask yourself who pays and who benefits. The subsidy the U.S. government gives me on my mortgage every year is 50% greater than the subsidy given for food stamps to poor people. And quite frankly, I need it less than they do. I get a tax deduction on my charitable giving. The subsidy I get on my charitable giving is greater than the people would get in the United States for food stamps. Every time you see a subsidy, ask yourself who pays and who benefits. And so we're looking at a world that's really different from before, again, because of this desire to help promote health systems that work and help ensure that they're coupled to financial arrangements that prevent the poor from being bankrupted and that provide insurance. Let me just say two last things. I'm not going to talk about swaps. Results-based financing is a rage, but there seems to be increasingly good evidence that it works. And the idea of results-based financing, as I'm sure you know, began in Mexico and then Brazil and is now spread to much of the world, first through Latin America. And the idea basically is conditional welfare programs. This is a mother who is poor, who lives in Oaxaca State, and what we're going to do is give her we're going to give her assistance, financial assistance to help her country, to help her family rise out of poverty, and to ensure that her children are not as poor as she is. To do that, we're making a contract with her, and in order to get her subsidy from the government every month, she has to take her children for well baby care, she has to immunize her children, she has to send the children to school, the children have to attend at least 95% of the time, she has to also go to antenatal care herself, deliver in a hospital, etc. The Mexicans began this with the program. It was continued under successive governments, and in many respects as the grandmother and grandfather of this. The Brazilians, as you probably know, have a program called Bolsa Familial, which certainly the Brazilians believe has been really instrumental in helping Brazil dramatically reduce the rates of people who are poor in Brazil. And there's demand and supply side financing. And on the supply side, if she's running the health system, and who's going to Rwanda? Nobody? Okay. In Rwanda, as you may know, or you'll find out soon, a lot of the system is based on the notion of supply side incentives. You could say they should do their work anyway, but what they're doing is saying, if you meet these targets for A, for B, for C, and for D, then your health center, your clinic, your hospital gets a bonus, 60% of which you can put into the development of the hospital and 40% of which, for example, goes to staff. Another well-known conditional cash transfer is India has a program, as you probably know, for encouraging women to deliver in hospitals. When I first worked on India, fewer than 15% of the women in India gave hospital births. In principle, you want every woman to have a hospital-based delivery, but beware of one other thing I haven't mentioned here. There hasn't yet been a theme on quality, and I would encourage you to think about quality. Poor quality education is a waste of money. Poor quality health care kills people, and there's been very little attention. There's some push now for quality, but there's been very little attention to quality. Betsy Bradley, who you met, and is a great woman, has done some remarkably good work in a number of environments on quality. But I can't stress enough how much I would encourage you to ensure that what you do gets done well and what you help people to do gets done well too. Because if not, it's both a waste of money and puts people's lives potentially at risk. Let me just say two last things and I'll come to lessons, but interrupt me. So look, if you look at this, and I think it's probably a little bit too light, but basically this is a slide that looks, I skipped one, let me go back, sorry. So this is development assistance for health, and the story is pretty clear. There used to be in 1990, there was $5 or $6 billion a year going as development assistance for health, of which, by the way, something like almost $2 billion was the World Bank. And now we're living in a world where over $30 billion per year is being provided for investments in global health. And the largest purveyors of the Global Fund, Gavi, and the Gates Foundation. The World Bank has become much smaller. And then you'll see the bilateral organizations are also providing substantial sums, with the U.S. providing the most of all. If you look at a one-year snapshot, this looks at by provider. And here you see how dramatically the world has changed. Here's the World Bank in here providing a little less than $1 billion. Here's Bill and Melinda Gates Foundation, $1.3 billion. Here's the Global Fund at about $4 billion. And U.S. at $7.4 billion, a lot of which is HIV. If you look at the content of what they're providing money for, an important part of this has been HIV. HIV, TB, and malaria since the beginning of the Global Fund, the beginning of the PEPFAR program, have been very, very dominant. In the last few years, funding for HIV as a share of the total has actually gone down a little bit. Funding for neglected diseases has gone up a little bit. Overall funding, despite the world recession, has stayed pretty constant, which is better than most people thought. And you can go to the Institute. I'll give Heather and Barbara a reference for you. There's a very good piece by the Institute of Health Metrics from which this data comes that looks at how this lending has changed. Now, one really interesting thing is, let me ask you, what's the leading cause of death for the world as a whole? Anybody? Anybody? Cardiovascular disease. Now, one other really critical theme, starting in the 1990s, has been the idea that you should base your investments in health on the burden of disease. And the first burden of disease study came out in '93, the second, I think, in 2006, and the last one last year. And everybody really should be familiar with the notion of the burden of disease, which Chris Murray from the Institute of Health Metrics and Evaluation is the main purveyor of. But in the global health business, this is really central. You start by you start by asking yourself, what is it in country X and Y that people get sick, disabled, and die from? Who is it that gets sick, disabled, and die of those things? Why do they get sick and die of those things? And what can we do at least cost to help to address those matters and help them live long and healthy lives? If you were my students, you'd have to do 3 policy papers. It would also give you a headache, but you would know very well Skolnik's view of the world. And they're actually to one other question. And I encourage you to think about this. What is it that people get sick, disabled, and die from? Which people are you talking about? The North, the South, the East, the West, the Kron, the Kru, the Mandingo, the Hausa, the Fula, the indigenous peoples in the Americans, the lower caste in India, the HIV-affected people. Why do they get sick and die of these things? And these studies look not only at what they get sick and die from, but also what they call the determinants of health. Why should the minister and the president care about these things? How will you frame your arguments and evidence to convince them that these are worthy of investment? And lastly, what can be done at least cost to address these problems? And I think you want to be thinking about best buys. You want to be thinking all the time about value for money. And as you know, things like immunization, directly observed short-course chemotherapy for tuberculosis, these are really good buys. Let me end with a couple of really gratuitous comments. You probably thought all my comments were gratuitous so far, and that's okay. And this is some lessons, quite obviously, according to Skolnik, which I hope, of course, you will nonetheless adopt and make dear to everything you take with you from here on out. One is, as you think about the work you're going to do, the work that's been done, the history of global health, one important lesson is don't be ideological. Here's my example. How many of you believe that all Bangladeshis deserve access to safe drinking water? All poor Bangladeshis deserve access. Anybody? I see a few people who believe Bangladeshis don't deserve access to safe drinking water, but they're the first people who've ever been asleep when I gave a talk. Now, how many of you believe that the government of Bangladesh today is capable of providing safe drinking water to all of its people? Okay, I love Bangladesh, I love the Bengalis. You've never been in Bangladesh. Don't take it personally. They're not. Okay, it's not going to happen. So you got a problem. People deserve to have access to safe drinking water, but the government's not competent to do this. So you got to ask yourself, in this setting, what can be done to ensure that people get access to safe drinking water at reasonable prices, which might be free? And in Bangladesh, where you have BRAC, Grameen, and the largest NGO sector in the world, your best bet might be to contract out those services. Now, in the United States, contracting out is regarded as a right-wing plot. I want to suggest to you that you not worry about right-wing or left-wing, but you always ask yourself, under these circumstances in this country today, what is the most sensible approach to achieving goal X or Y at least cost? If you do that, I think you'll be on the right track. If you don't do that, you're going to suggest solutions that make absolutely no sense just because you have a non-evidence-based ideological approach that I would discourage you. Don't be faddish. I'm 64. I've been doing this for 40-some years. I cannot tell you how many fads I lived with, most of which had no basis in evidence. Just forget faddish. On the ideological also, a really important lesson from Robert McNamara. I got to see a showing of The Fog of War with a relatively small group at the World Bank with Mr. McNamara present before he died. And at the end, somebody said to Mr. McNamara, if you could do it all over again and you had one lesson only you could provide to people, what would you say? What would you say to young people today is the most important lesson of life that you've ever learned based on your experience with the Vietnam War? And Mr. McNamara said, always question your fundamental assumptions. He said, you probably won't believe it, but I sat there with the Bundys and Ted Sorensen and all the best and the brightest. And because of the history of the McCarthyism and communism and the fear that the Red Menace would take over Southeast Asia and Thailand, Laos, and Vietnam would fall like dominoes, never at any time, he said, did I ever walk in a room and say to people, is it possible we're wrong? Is it possible that this is just another part of the Vietnamese struggle for liberation like what they did against the French? At no time did ever do that. And I think in fairness to Paul Farmer, Jim Kim, I think the real lesson of Paul's work, in my view, and this is on film, I'm happy to say it, is not partners in health. It's the unwillingness to accept the world the way it is. And it's the not only unwillingness, but Paul's absolute insistence that you question fundamental assumptions. The world had been given donations of drugs since the onchocerciasis program, when ivermectin, which you give your dogs, was found to be useful for humans. So when HIV became rampant, there were already historical precedents for drug donations, but people hadn't thought about it. I mean, instead we were thinking, oh, at $13,000 per year, this is never going to work. Countries are never going to be able to afford this. And Paul and others insisted that the world just forget the idea that they cost $13,000 and ask, how will you get drugs to poor people? Well, I don't care what they cost, these folks said. How will you get drugs to poor people? And I think that's a very valuable lesson. I don't know if Paul would be happy of my conjoining him and Bob McNamara, but in a certain way, both of them said the same thing, and I encourage you, as you think about the sweep of global health in your work. Communities and context matter. Everything is local. You can read the debate between Jeff Sachs and Bill Easterly. You can decide where you are. I'm not sure it matters that much. I think what's really fundamental is understanding that people, one way or the other, need to be involved in identifying their own problems and solving them and mobilizing around those solutions, or things are never going to work. This isn't something that was discovered yesterday. I mean, when I went to school, and that was a long time ago, this was considered central, but in some respects, people have probably never done enough of it. And remember, technical solutions only solve if they work. There's a good joke. I don't know if this is on film. I'm going to tell it. It's not off color. You can make this for any religious group. There's a rabbi and a priest in Madison Square Garden, and the rabbi says to the priest, "Father O'Malley, we've been best friends for 25 years. I see the boxer, before he got in the ring, got down on his hands and knees, and he made the sign of the cross. As my best friend and as a priest for all these years, please tell me, as a rabbi, what does it mean when the boxer gets down on his hands and knees and makes the sign of the cross?" Father O'Malley puts his hands or his arm around Rabbi Goldberg, and he says, "Rabbi Goldberg, honestly, between you and me, even though I'm a priest, it doesn't mean a damn thing if you can't fight." Now, I would encourage you to keep this in mind. No one cares more about directly observed short-course chemotherapy for TB than I do. It's highly cost-effective. Vaccines for childhood diseases are unbelievably cost-effective, but not if the kids don't get vaccinated. Not if the cold chain doesn't keep it cold if it has to be cold. Not if the vaccines don't get out there. If the TB drugs are counterfeit or can't be delivered or people don't take them, doesn't matter how much you believe in directly observed short-course chemotherapy. That's all talk. It's just theory. So you can translate that joke into whatever religious group you want, but I encourage you to remember content and execution really matter. Two last things I've said before, but I'll say again: money matters, but value for money. There's a long history of work in global health, and one disappointment, I think, for many of us is there's still not sufficient evidence to know exactly what works at what cost. I would encourage you wholeheartedly to try to ensure that you get as good a fix as you can on what works at what cost, and to ensure that independent views are evaluating at all time what gets done. That's good practice. If you can't do a randomized controlled clinical trial, that's okay, but at least let somebody else look at what you're doing. I think you will learn much more, get a much more objective view, and begin to gather more evidence on what works and doesn't. One thing I left out here is, and then I'll end, is if I had organized my book according to the burden of disease, I'm coming to this late, for which I apologize. If I had organized my book according to the burden of disease, let me ask this young man, what share of the pages should have focused on non-communicable diseases? If I had organized my book according to the distribution of the burden of disease globally, what share of my book should have focused on non-communicable diseases?
About a quarter.
Actually, it probably would be something like 60 or 65. Actually, about 60% or so, 65% of the total global burden of disease is non-communicable. And only in sub-Saharan Africa today are communicable diseases predominant. Now, I didn't do that because how many of you want to read about ACE inhibitors and beta blockers? How many of you, let's see, how many of you would rather, this young lady, she's good. How many of you would rather read about TB, HIV, malaria, child survival, maternal death, fistula, etc.? Almost everybody. And there's not that much to say. But one of the things you have to keep in mind as you work on health is these countries are all past the transition. In every country, the burden of disease is moving toward non-communicable diseases. Many countries, including the poorest, have an opportunity now to get a fix on tobacco, which is probably the single most important thing they can do. They can begin to get a fix on some nutritional issues, which are really critical. And if they don't, they're going to wake up with a nightmare even worse than the one they have, with a terrible burden of disease that's hugely communicable, hugely non-communicable, and lots of people dying on the roads. The last thing I'll say is, despite my insults to the idea of process, there are some things that can only be addressed by people working together. We're not going to be able to address the issue of vaccine-preventable diseases If pockets of people in California don't immunize their kids, or pockets of people in England don't immunize their kids, or there are large pockets of unimmunized kids in Nigeria or in India. We're not going to be able to solve the problems of a lack of drugs, diagnostics, and vaccines if we act as islands and don't work together. And whether we're thinking about problems that largely affect poor countries or we're thinking about problems that transcend boundaries, there's very good evidence that the principles behind working together for global health are good ones, and hopefully some of you will be involved in helping the world to ensure that it continues to learn from the history and act ever more responsibly, ethically, effectively, and efficiently as we seek to cooperate to make the world a better place.
I think, I'm going to be the person to cut this off. We have to break for lunch right now because we have to be back here at 2, but the good news is that Richard is joining us for lunch right now. So I know there's a lot of hands in the air. Save your questions. Talk to him over lunch, and also he's going to join us tonight at 7:30 also, so there will be plenty more time.
Take more Valium before tonight.
Don't take Valium.